And the benefit of that recording is that obviously anyone that can't make it today still gets the opportunity to see the presentation. So we're all good to go, I think, Salma. So I'll hand over to you to introduce yourself, if that's all right.
Wonderful. All right, good morning. My name is Salma, and I'm here today to talk to you about the MND Specialized Speech Pathology Service that is being offered at MND Queensland. So I'll be talking a little bit about who I am, the vision for the service, and a little bit about my research. So I am from Calgary, Alberta, Canada. However, I completed my Bachelor of Science at the University of Alberta, which is located 3 hours north of where I was born, so in Edmonton. I moved to Australia 7 years ago to study my Master's of Speech Pathology Studies and began my PhD afterwards in 2016, investigating dysarthria in people with MND over a 12-month period. Now, the role of the MND-Specific Speech Pathology Service is to help people with MND to swallow safely through behavioral modifications and changes in food and fluid consistencies with disease progression. Furthermore, the MND-Specific Speech Pathology Service will aid people with MND to participate in activities of daily living using speech and/or other means of communication, such as assistive technology. Now, the framework for the service is based on patient-centered care, or PCC. PCC is a healthcare management approach grounded in a symbiotic relationship between patients, family members, and healthcare professionals, with the patient and their healthcare needs as the primary focus. PCC has a positive impact on clinical outcomes, patient satisfaction, patient well-being, and participation in activities of daily living. Our speech pathology service will be based on an integrated PCC approach outlined by the article conducted by Scholes and colleagues from 2014. This approach consists of 3 main components: principles, enablers, and activities. And within these components are 15 dimensions. All 3 categories need to work together and inform one another for a seamless PCC approach to occur. So for example, the principles outlined can be adhered to by conducting certain activities, while the enablers help with the execution of the activities. Now, focusing on the principles, an example of essential characteristics of a clinician may include empathy, respect, self-reflectiveness, as well as clinical competency. The clinician and patient relationship should entail trust and caring, while patient uniqueness should include recognizing that patients are individuals and have preferences, needs, feelings, and beliefs that are unique to them. The last point is enabling and incorporating a biopsychosocial perspective, which includes recognizing the patient as a whole in his or her biological, psychological, and social contexts. Now, while the other principles are very important in the service that will be delivered, I will be focusing on the biopsychosocial perspective for the next few slides and how it will be incorporated into the speech pathology service. Now, the International Classification of Functioning and Disability and Health was developed by the World Health Organization in 2001. The ICF is a biopsychosocial framework that focuses on a person's level of health instead of their disability. Clinical use of the ICF framework allows for the description of all dimensions of health and function and considers the bidirectional nature of impairment, activities, and participation. According to the ICF, health is comprised of 2 parts: functioning and disability, so body structures and functions, activity and participation, and contextual factors, so environmental and personal factors. Furthermore, The ICF integrates contextual factors, including personal and environmental factors, as they influence the functioning of people with health conditions. Now, for this reason, I am bringing up this framework because the specific service for people with MND will be using the ICF to guide assessment and management of dysarthria and dysphagia as part of PCC. Given the far-reaching effects of dysarthria and dysphagia on activities of daily living and psychosocial well-being, a holistic approach can more accurately capture the extent of the unique difficulties faced by people with MND. I acknowledge that both dysarthria and dysphagia are extremely challenging conditions resulting from MND. However, I will use the ICF to explain dysarthria assessment and management today. So within the context of the ICF, dysarthria, which is a motor speech disorder, is an impairment, while speech intelligibility, how clear a person can speak so that her speech or his speech is comprehensible to a listener, is the activity. Participation is characterized by being able to participate in activities of daily living using communication. So while a person with MND may experience progressive dysarthria and in turn reduced intelligibility, speech pathology intervention can help people with MND continue participating in activities of daily living using communication. For example, introducing augmentative and alternative communication strategies, assistive technology, and communication partner training may help in this endeavor. Furthermore, understanding of environmental factors allows for generalizing therapy outcomes to environments beyond the clinical setting and to address environmental factors impacting functioning of people with communication difficulties. Personal factors, including ethnic background, gender, and previous experiences, can aid speech pathologists to better understand the individual with MND and adapt and individualize services to meet their needs. Now, previously mentioned, enablers help us assist activities. Enablers may include verbal and nonverbal communication between clinician and client, recognizing and integrating non-medical aspects of cares such as support services, and understanding the importance of effective teams and facilitating development of these teams. Activities that help support the principles of PCC include provision of information to patients' needs, which can be accomplished through education sessions, active involvement and collaboration with the patient in decisions regarding their health, as well as healthcare preferences. So for example, goal setting and reevaluating the goals over time with changing priorities. It is also important to actively involve family and friends based on the patient's preferences. So for example, communication partner training. And lastly, empowering the patient to self-manage their condition by providing tools for independence through, for example, assistive technology. Now, MND-AQ is working on developing a clinic room within the association's facilities where face-to-face speech pathology services can occur. So currently what's happening is the service is going to patients' homes or clients' homes, and we're trying to expand this so that people with MND and their families have the opportunity, if they would so like to, and come into the association for the service. Furthermore, we are working on developing and providing a voice banking service where you can book in to come to the association and use that program that has been set up. We are hoping to bridge the gap between the desire to record one's voice and the difficulties accessing and or using the voice banking software. It is also recognized that face-to-face services is not accessible for everybody, including those with mobility difficulties, funding difficulties, and for those who are living in rural and remote regions. Therefore, we are currently in the process of researching and developing an evidence-based MND-specific speech pathology telerehabilitation service. Now I'm going to talk a little bit about my PhD. So I conducted my PhD at the University of Queensland through the School of Health and Rehabilitation Sciences. My supervisory team consisted of Assistant Professor Noreen Escarinzi, Dr. Rebecca Nund, Dr. Anna Rumbach, and Associate Professor Patria Cornwell, who works with Griffith University. I would also like to give a special thank you to the Prince Charles Hospital Foundation for supporting my project through the provision of a PhD scholarship. Now, my study or my PhD consisted of 4 studies, which are listed on the slide. I will be focusing on the first study, which researched the impact of dysarthria in the early stages of MND using a cross-sectional methodology. So while this study is going to be aimed at people with MND, there may be some terminology that will be known to allied health professionals and/or researchers. So as many of you know, motor neuron disease is a fatal progressive neurodegenerative disorder resulting in deterioration of motor neurons. Males are more affected than females, and there is no cure. Therefore, symptomatic management is required. Progressive loss of communication is one of the most distressing and debilitating symptoms of MND. So the main communication difficulty experienced by people with MND is dysarthria. Dysarthria occurs when the muscles you use for speech are weak or you have difficulty controlling them. Dysarthria often causes slurred or slow speech that can be difficult to understand. Dysarthria is the initial symptom of MND in approximately 30% of people experiencing the disease. Furthermore, people with bulbar onset MND are likely to experience speech deterioration before diagnosis and access to speech pathology services. However, presentation is variable due to age at onset, site of onset, and rate of progression. For healthcare professionals, early presentation of dysarthria is either spastic or flaccid and eventually becomes mixed in the later stages of the disease. In turn, dysarthria is likely to impact communication effectiveness across social situations for people with MND. This in turn restricts the ability to participate in activities of daily living. Interestingly, self-perception of communication effectiveness is often a key indicator of declining communication ability in people with MND. Reduced ability to use speech or speech loss therefore has a negative impact on social interactions and vocational roles in people with MND, which may lead to psychosocial consequences for this population. For example, living a passive or more isolated lifestyle leads to feelings of frustration, isolation, control issues, and negativity. However, little is known about the early stages of dysarthria and the impacts on activities of daily living and psychosocial well-being for people with MND. Therefore, this study aimed to explore dysarthria presentation and its impact on communication effectiveness and psychosocial well-being in people recently diagnosed with MND. Due to the complex and rare nature of MND, a cross-sectional multiple case study design was employed to explore the similarities and differences of experiences of dysarthria in 7 cases. Participants were eligible for inclusion in the study if they had a recent diagnosis and formal diagnosis within 6 months and were able to provide informed consent. Individuals with MND who were 7 months post-diagnosis or later presented with a severe cognitive impairment, dementia, or other substantial medical, neurological, or psychiatric disorders, or were not proficient in English, were not eligible to participate. This methodology utilized both quantitative and qualitative methods to provide complementary data and to conduct counterpart analysis. In short, different data sources provided a more comprehensive understanding of the findings. Now, theoretical propositions or statements were developed to guide the study design and method, including data collection procedures and strategies of data analysis. 3 theoretical propositions were developed by reviewing the literature related to MND, communication decline, and associated psychosocial impacts, discussions with my supervisory team, and developing a thorough understanding of the study aim. Proposition 1 suggests communication function and the nature of dysarthria will be highly individual for people with MND in the early stages of the disease. Proposition 2 suggests the ability for people with MND to communicate effectively within activities of daily living will be impacted by the presence and severity of dysarthria. And Proposition 3 suggests people who have a more severe dysarthria in the early stages of the disease will have lower levels of psychosocial well-being. Now, data collection occurred over 2 sessions at either participants' homes or at the University of Queensland to reduce fatigability. Session 1 was used to collect clinician-rated measures and patient-related measures, including the Frenchy Dysarthria Assessment 2nd edition, the ALS Severity Scale Speech Subsystem, the Modified Communication Effectiveness Index, the Dysarthria Impact Profile, and the Depression Anxiety Severity Scale short form. Session 2 involved an in-depth, semi-structured interview. Using an interview guide, participants were asked to discuss their experience of MND, communication before and after their MND diagnosis, awareness and adjustment of their communication impairment, impacts of communication impairment on relationships, changes to roles and responsibilities as a result of their communication impairment. Data analysis included a descriptive statistical analysis to summarize the data for individual participants on the following assessments, including the FDA-2, the ALS-SS, the SETI-M, the DIP, and the DAS-21. Data analysis of the in-depth semi-structured interviews use steps from thematic analysis as outlined by Braun and Clark 2006. Coded interview data was clustered into categories and subcategories meaningful to the study. However, themes were not developed due to the nature of the study. Analyzed data sets were merged and associated with a specific proposition to ensure relevance to the focus of the research was maintained. Proposition 1 was addressed by outcomes from the FDA-2 and ALS-SS. Proposition 2 was addressed using the FDA-2, the ALS-SS, and the SETI-M, and Proposition 3 was addressed using the DAS-21 and the DIP. Interview data addressed all propositions. Now, all cases with bulbar onset MND presented with a dysarthria. Therefore, Proposition 1 was upheld. 3 cases presented with a mild dysarthria, including 1 spastic, 1 flaccid, and 1 mixed dysarthria. And 2 cases presented with a mild to moderate dysarthria, 1 spastic and 1 flaccid. However, dysarthria was reported to be a gradual process in the early stages of the disease. Both cases with spinal onset MND did not present with a dysarthria or changes in functional verbal communication. However, all cases with bulbar onset MND and 1 case with spinal onset MND presented with reported laryngeal impairment. Experiences of laryngeal impairment differed across participants, with participants reporting changes in either vocal quality, pitch, or loudness. Those with mild to moderate dysarthria presented with changes to their respiratory system and lip function, in addition to impairments to laryngeal and lingual impairments. Now, Proposition 2 was partially upheld. The greatest reduction in communication effectiveness was in the 2 cases with the most severe dysarthria and lowest functional communication scores. However, reductions in communication effectiveness between those with mild dysarthria and cases without dysarthria were not discernibly different. Reduced communication effectiveness in cases without dysarthria were caused by reported co-occurring impairments such as hearing impairment, fatigue, and reduced respiratory support. As a consequence of reduced communication effectiveness, participants experienced impacts to socialization, occupation, and difficulties having their needs met. Next, Proposition 3 was not upheld. All cases experienced an impact on their psychosocial well-being, regardless of onset type and dysarthria presence. Cases with mild to moderate dysarthria reported a greater reduction to overall psychosocial well-being than cases with mild dysarthria. Specifically, dysarthria had the greatest impact on cases with mild to moderate dysarthria as speakers and changed the way they were able to communicate with others. Neither case with mild to moderate dysarthria presented with symptoms of depression, anxiety, or stress. However, 1 case reported feeling miserable, sad, and alone. Cases with mild dysarthria were most impacted by perception of others. Depression and anxiety reported by cases with mild dysarthria were linked to the lack of knowledge regarding disease progression. Cases that did not have a dysarthria or impaired functional verbal communication presented with similar reductions in overall psychosocial well-being as those with mild to moderate dysarthria. Cases without dysarthria had the most difficulty accepting potential dysarthria due to the role communication had on a person's life and the fear of speech loss. Anxiety in the cases without dysarthria were related to the experience of changing bodily function. So overall, our findings indicate early speech pathology services are vital for early detection of dysarthria, reduced communication effectiveness, and reduced psychosocial well-being for both people with bulbar onset and spinal onset MND. This will allow for relevant education, strategies, and technologies to be implemented in a timely manner. Furthermore, the unique presentation of dysarthria and factors impacting on communication effectiveness and psychosocial well-being require individually tailored and holistic speech pathology management of people with MND from the early stages of the disease, which then links back to the framework being used for the speech pathology service at MND Queensland. Thank you for listening to my presentation today. This will be uploaded to the website. I look forward to any questions you have that can be emailed to the email address provided on the MND AQ website.